So this is a patient who presented to us, 32 years old, family history of breast cancer diagnosed in her mother at age 47. And she presented with a right breast palpable finding. Mammographically, this was occult. There was a BB placed on it and nothing was seen on the right side. And incidentally, on the left, we found a focal asymmetry. Targeted ultrasounds were done on both sides. The same day as her diagnostic mammogram, we did the diagnostic ultrasound, and the palpable finding really stuck out like a sore thumb on her ultrasound because she's fairly dense, and even though it was mammographically occult, right 10 o'clock, 2 centimeters from the nipple, we had a 2.3 by 1.7 centimeter mass, which was irregular and some internal vascularity. We looked to find a correlate for the left finding as well, and there was a small correlate found at left breast 9 o'clock, 6 centimeters from the nipple, fairly posteriorly. She went to our breast surgeon, and this is kind of a pet peeve of mine. I like to keep things very similar. The day of our diagnostic, we called her palpable lesion 10 o'clock, 2 centimeters from the nipple. The breast surgeon called it 12 o'clock, 2 centimeters from the nipple. It's obviously the same lesion, and it's a fairly large lesion, so that was sampled. This came back invasive ductal carcinoma. At this point, she still hadn't had her left breast biopsy, so she went back to the breast surgeon. And the region that we had found to correspond with her mammographic finding was left 9 o'clock, 6 centimeters from the nipple. Although this is labeled left 9 o'clock, 6 centimeters from the nipple, and I can't see in any of the images whether the lesion was actually sampled or not by our breast surgeon. No post-biopsy mammogram was done. The left breast was benign, and it was called concordant. It was just called benign breast tissue with fibrocystic change. At this point, a breast MRI was ordered. She's fairly young. She's dense. She had a mammographically occult mass. All good reasons to get a breast MRI preoperatively. So we see lots of enhancing masses in the right breast. The largest one was biopsied, and the clip is in accurate position. This is an example of multifocal because we're in the same quadrant of the breast. And also multicentric disease below the nipple. She has extensive multifocal and multicentric disease. Additional focus in the anterior upper inner quadrant as well. So now let's take a look at where our clips are. So here is again our site of entry. You can see some enhancement there that was unsampled, and then we see our biopsy clip, fairly external to the larger site of enhancement. Scratch that internal to the area of enhancement here. That's the only sampled area. There's lots of other multifocal and multicentric disease. On the right side, let's continue on with our search. We see a pathologically enlarged lymph node, rounded morphology, not a lot of fat. This is suspicious. Because there's so much disease, we want to make sure we look at the sternum carefully on our T1 post. We want to make sure we look at our internal mammary vessels carefully as well. And as of now, the left breast has multicentric disease and axillary nodal involvement. Now, the benign area that was biopsied, we can see our surgeon clip. We didn't have a post-biopsy mammogram, but we do have a post-biopsy MRI, is located here in the anterior breast. The area of enhancement and irregular mass is located here in the posterior breast. So although she was in the right quadrant, we didn't actually sample this. Unfortunately, patient elected to have a mastectomy with a deep reconstruction. She jumped around from location to location, so I don't think the lack of concordance in the left breast was communicated to them. So the bilateral mastectomy specimen, there were 3 separate foci of IDC identified in the right breast, and the left breast was called benign. Unfortunately, we never really resolved what was truly at 9 o'clock, 6 centimeters from the nipple. Her story doesn't end there. She had a right skin recurrence found on punch biopsy in 2021. So she got a PET scan. In 2021, lots of people were starting to get COVID vaccinations, and you can see on her PET scan that even though she had a right-sided skin recurrence, you can see surgical clips throughout both breasts from her deep reconstruction, she had lots of large left axillary lymph nodes. These were called very suspicious, and a biopsy was recommended. We did an ultrasound, and we were able to gather that additional history. We were able to say it's the upper limit's a normal, nice fatty hilum, probably reactive lymph nodes in the setting of COVID vaccination. We repeated that PET scan from May to June, so about 6 to 8 weeks. And the FDG avidity, although the lymph nodes are still there, has decreased substantially, which cancer would not do. And this was proven to be, without a biopsy, reactive adenopathy on PET-CT. It's important to continue getting the same history from your COVID vaccination history that you get on your mammograms and screening mammograms, also on your diagnostic mammograms and your MRIs and PET-CTs. Hi, I'm Priyanka Honda. I am fellowship trained in breast imaging from Emory University, and I've worked in private practice for the last 5 years and trying to collaborate with our breast surgeons and oncologists to give them the most clinically useful information when they are managing their recent diagnoses of breast cancer. One of the things we're going to touch upon is how to adequately provide tumor sizes, distance from the skin, and adequate information for the patient to be staged with the TNM classification prior to them going to the operating room or getting neoadjuvant or adjuvant chemotherapy. Stay tuned and we'll get right into it. So this is a 54-year-old female who was called back from her screening mammogram in August 2019, and she had a large right axillary lymph node, kind of sticks out like a sore thumb there. At this point, an ultrasound was performed. An ultrasound was performed of the right axilla, and we can see that there's cortical thickening on this outside facility ultrasound. The most important measurement with an ultrasound of the lymph node is usually the cortical thickening. And we get about 0.6 centimeters here, which is above the normal threshold of about 0.3, and an ultrasound-guided biopsy was performed. The right axillary lymph node pathology was consistent with adenocarcinoma of breast primary. At this point, a full mammographic and sonographic workup failed to demonstrate any site of primary malignancy in either breast. Appropriately, as per the ACR criteria, an MRI was ordered. So this is the MIP image here. We can see the biopsy-proven malignancy in the axilla of nodal morphology here on the MIP. And even on the MIP, you can see that there's a Christmas tree bright, but very small focus of enhancement. So let's inquire some more. So here is that biopsy-proven axillary lymph node. There's a susceptibility artifact related to the clip and a unique focus of enhancement above background parenchymal enhancement, which I would say is mild background parenchymal enhancement. This is a large-breasted woman, and you can see there's flattening of the nipple areola complex. In fact, it almost looks like she has an inverted nipple, not to be confused with a subareolar cancer. So let's take this time to review some BI-RADS terminology. In every MRI report, you want to start off with the amount of fibroglandular tissue, entirely fatty, scattered, heterogeneously dense, or extremely dense, just like your mammography report. Then you want to report on the background parenchymal enhancement, minimal, mild, moderate, or marked. You can comment on if there's symmetric or asymmetric fibroglandular background parenchymal enhancement, maybe in the setting of radiation therapy. And then the next thing in our BI-RADS lexicon for MRI is a focus of enhancement. So the lymph node that was biopsied was a mid-axillary level 2 lymph node. It's important to know the anatomy. We're going to discuss Rotter's nodes as well, which are interpectoral lymph nodes, supraclavicular lymph nodes, and what the management is and what is covered in a sentinel lymph node biopsy versus a complete axillary lymph node dissection. Important to describe where you're seeing the lymph nodes with respect to the pectoralis minor muscle in order for accurate staging. So now we hone in on that image, on that focus of enhancement. You can also see that you have that nipple areola complex there. The discussion of kinetics is important here. For the most part, type 1 or persistent kinetics tend to be associated with benign etiology. So you can see with the nipple, that was a persistent kinetics and not something to be worried about. And also just anatomically, you know that there are symmetric bilateral areas of enhancement at the nipple. Type 2 plateau kinetics tend to be intermediate. And type 3 washout kinetics is what's worrisome for a washout cancer. Also, sometimes you see this with intramammary lymph nodes. So not everything that's type 3 washout kinetics will be a cancer. Kinetic assessment. Morphology is more helpful than kinetic behavior. Kinetic heterogeneity of lesions is common. Management should be based of course, first on morphology, and then the most suspicious kinetic pattern, not the dominant kinetic pattern. So even if there's a tiny pixel of washout, the washout determines the worst kinetic behavior, and that's what it should be based on. As discussed, normal lymph nodes show washout kinetics, and those are the only ones we can ignore based on morphology. So our focus of enhancement, you can see, it is demonstrating type 1 and type 2 kinetics. Our lymph node, even though this was a pathologically enlarged lymph node based on the morphology of being 6 millimeters of cortical thickening, it is behaving like a normal lymph node would, as is on the other side, showing washout kinetics. So this was a intermediate kinetics based on the fact that this patient already had biopsy-proven cancer in the axilla. An MRI-guided wire localization was performed. And her final pathology, there was invasive ductal carcinoma measuring 0.4 centimeters in that focus of enhancement, which metastasized to that large right axillary lymph node. The summary points and takeaway from this case are mammographically occult breast primaries with mets to the axilla require breast MRI. A focus of enhancement when greater than 0.3 centimeters can be biopsied or localized for your breast surgeon. Anatomic relationships of the axillary lymph nodes with relation to the pectoralis minor muscle are important to describe for your breast surgeon and your oncologist. This case is about a 45-year-old nurse who presented with no family history of breast cancer, and she had a right breast palpable mass in June of 2020. Mammographically, it was relatively occult in her heterogeneously dense breast, but there was an appropriately recommended ultrasound-guided biopsy of a vague and hypoechoic mass at 11 o'clock, 9 centimeters from the nipple. The patient refused biopsy at this point and chose to follow it. In the meantime, there was increased coarse heterogeneous calcification and dystrophic calcifications, but more mass and more microcalcifications. Another ultrasound was performed in June of 2021, approximately a year after the initial palpable finding with increase in size. And now you can see a more defined mass at 10 o'clock, 13 centimeters from the nipple, almost in the axillary tail, measuring about 1.2 centimeters, taller than wide, hypervascular, and extremely suspicious given its growth in the past year. An ultrasound-guided biopsy was recommended for this mass and for the microcalcifications. An ultrasound-guided biopsy was performed at 10 o'clock, 13 centimeters from the nipple with a bar-shaped clip, and then there's a barbell-shaped clip targeting the more coarse heterogeneous microcalcifications in the axillary tail. These were new mammographic findings in the last year, approximately 2.2 centimeters away from each other. This seems to be a bad player. It was acting quickly. The pathology results in this patient at the calcifications was DCIS, measuring up to 1.2 centimeters, which was high nuclear grade and associated with the microcalcifications, ER and PR positive. Additionally, the ultrasound-guided biopsy demonstrated invasive carcinoma with mucinous features, also ER and PR positive. The mucinous features demonstrate that this was actually perhaps a less aggressive cancer, but mammographically and sonographically, this had progressed relatively quickly in a year. So the patient was, of course, for her young age, heterogeneously dense breast tissue recommended for a breast MRI. We can see here that her right breast has extensive non-mass enhancement with an additional, the non-mass enhancement in the right upper outer quadrant with an additional posterior upper inner mass enhancement. Now this is an important mass to look at, and we want to look at it in multiple different sequences. Let's get a quick lay of the land with our MIP. On the MIP, you can appreciate that there is dense breast tissue along with moderate to marked background parenchymal enhancement, especially in that tricky lateral and posterior region. However, this is asymmetric and requires further investigation, and this was in the region of biopsy-proven malignancy. Our T2 sequence here is a STIR. We want to look at that medial mass enhancement carefully because that is not yet biopsy, and it might be a separate site of enhancement. There seems to be correlating T2 hyperintensity. In fact, when you look into the kinetics of this, it looks like it's persistent kinetics on subsequences, and there seems to be thin septations. We did a second look ultrasound and an ultrasound guided biopsy of the additional mass. Even on ultrasound, you can see that this is a wider than tall mass, and it looks like a fibroadenoma on MRI and on ultrasound. Of course, in a patient with known breast cancer, it's guilty until proven innocent, and it was proven to be a fibroadenoma. Additionally, in the left lateral breast, there was some area of non-mass enhancement. Patient was offered a second look ultrasound and biopsy. There was no correlate identified, and this would be an area that would likely require an MRI-guided wire localization rather than a MRI-guided biopsy, even of the more anterior location. Patient has opted for chemotherapy and mastectomy at this time, so no additional biopsies were performed on this patient. In summary, for this case, we want to remember the importance of providing patient history and description of all prior workup in our history. In report structure, you really want the dictated history to answer the following question: the who, the what, the where, the when, and the why. Give the patient age, family history, and hormone use history. The what. What's biopsy proven, what's extent of disease, and what's recommended for additional evaluation. Where. Define the biopsy location, which clips were used. It's important that in that case we specified which biopsy clip was associated with the ultrasound-guided biopsy and which biopsy clip was associated with the ultrasound-guided biopsy. Sometimes when the clips, one is malignant, one is benign, it's very important to distinguish which one needs to be localized for your fellow radiologist and for your breast surgeon. If there's clip migration, it's very important to denote that. Has there been recent or remote surgical treatment or radiation treatment? That can also dictate future management and how you read that breast MRI. Why are we doing this MRI? In this case, it was for preoperative management. Of course, this patient may decide that she wants neoadjuvant chemotherapy only, and we will assess response. So this here is a screenshot of the BI-RADS terminology note card that can be downloaded from the ACR and BI-RADS website. It's very important that when we use the lexicon that you know exactly where you're headed. This patient already had a biopsy-proven right breast cancer in the upper outer quadrant. In the upper inner quadrant, she had an oval circumscribed mass with dark internal septations. Usually oval circumscribed dark internal septations, you're really suggestive of a fibroadenoma, which would be a BI-RADS 3 in a patient without biopsy-proven malignancy. However, in this patient, it's guilty until proven innocent, so therefore, this was a BI-RADS 4. The conclusions that I want to touch on this case, it's very important that when you have a complicated case where this is a patient with right breast cancer already proven in the upper outer quadrant, an additional biopsy required in the right upper inner quadrant, and then additional biopsies recommended in the left upper outer quadrant, that each side, the laterality, should be separated in the conclusions. BI-RADS 4, if there's more to be done, even when it is a biopsy-proven malignancy. There are unsampled findings on imaging that could change the surgical approach, so BI-RADS 6 would not be appropriate here because it's less actionable than a BI-RADS 4. The next radiologist on this case should know exactly what to biopsy to resolve the BI-RADS 4 and make the patient a BI-RADS 6. That should be clearly delineated in your conclusion. Comment directly on the preoperative localization technique after the additional biopsies are performed, unless you are headed towards mastectomy. What I usually do, even in this patient, which ultimately they chose to go for mastectomy, is recommend the preoperative localization if breast conservation therapy is elected. On neoadjuvant chemotherapy, suggest any additional clipping that should be placed if the breast conservation therapy will be eventually considered. If you see additional disease on MRI, but the clips on mammogram do not match the extent of enhancement on MRI, it is appropriate to discuss with your breast surgeon and your medical oncologist whether they plan to remove all the diseased area post-operative, post-neoadjuvant chemotherapy in the operative setting. So additional clips may be required even if additional biopsies are not required. This is a 77-year-old female who was initially seen by dermatology for nipple redness with a normal screening mammogram in December of 2020. She even had a left breast diagnostic mammogram and ultrasound in July of 2021, which was read as normal. She had a Wedge resection performed by a dermatologist in the left nipple on July 30th with results of infiltrative carcinoma favoring a lobular pathology, and all the margins were positive, of course, because this was a breast cancer with a skin excision performed. Here we can see the nipples that there is asymmetric enhancement. Sometimes this is seen in Paget's disease. On the left side, this is not a normal nipple. Of course, this would be more confusing if the patient had previously received radiation therapy on the right or had a surgical excision on the right, that this would be asymmetric. But here, given the clinical history, we know this is pathological enhancement, not physiological enhancement. The goal of performing an MRI when you have a skin malignancy of breast primary is to identify if there's any intraparenchymal disease. At this point, we had a negative screening mammogram, a negative diagnostic mammogram, and ultrasound. However, MRI finds additional enhancement. We're going to go and really see that we have an irregular, heterogeneously enhancing mass that we see on MRI. Of course, an option would be to do a second look ultrasound here, or perhaps jump right to MRI-guided biopsy. There are some delays in proceeding with MRI-guided biopsy. When I was reading this mammogram, I was curious that this significant amount of enhancement didn't have any correlate on mammogram. So I went back to her diagnostic mammogram. So on the left lower outer quadrant, we saw MRI enhancement. And going back to her diagnostic mammogram, it's actually evident that there is architectural distortion associated with a small irregular mass, as you can see here on mammogram. We looked on ultrasound as well, and there was not a very good target on ultrasound, so we proceeded with a stereotactic biopsy of this region in the left lower outer quadrant in this patient with known areolar malignancy. And if you remember the pathology, it was actually favoring a lobular pathology at the skin excision, but when we did a stereotactic biopsy, the ultimate pathology was ductal, and it was poorly differentiated ductal carcinoma. This patient did go for a lumpectomy with our breast surgeon, and the nipple areola complex was also excised in addition to the left lower outer quadrant region of malignancy. The take-home points from this case are that we want to correlate prior mammograms even when they're read as normal by other readers, because we have extra clues, we have enhancement. And perhaps in the future there will be diagnostics with contrast-enhanced mammography where we can find these on the day of the diagnostic mammogram. But if we can find a better correlate with ultrasound guidance or stereotactic guidance biopsies rather than MRI-guided biopsies, we can potentially provide a pathological diagnosis to the patient and the surgeon sooner and with less discomfort to the patient. This case is of a 63-year-old female with a family history of breast cancer in her sister, diagnosed in her 50s, and paternal grandmother at a postmenopausal age. She presented with abnormal segmental distribution, pleomorphic calcifications, recommended for stereotactic biopsy, and we'll look at the images after we review some concepts of non-mass enhancement on MRI. The first branch point is to look at the distribution. Is a distribution linear or segmental? Just like calcification distribution on mammography, linear and segmental are highly suspicious distributions that require biopsy, no matter if there's homogeneous or heterogeneous internal enhancement characteristics. If the distribution is focal, non-mass enhancement, or regional, or multiple regions, or diffuse, there's a possibility that this may be background parenchymal enhancement, especially as we detailed in the posterior, lateral, and inferior breast. When there's symmetric enhancement, that's more likely to be background parenchymal enhancement. Now, if it's focal, regional, and there are multiple regions or diffuse, the internal enhancement is very, very important. The internal enhancement characteristics of clumped or heterogeneous clustered ring still require a biopsy. If the internal enhancement is homogeneous rather than heterogeneous, and it's associated with fibrocystic change on the T2, it is actually more likely that it'll be benign and associated with background parenchymal enhancement. Now, if there's no associated fibrocystic change on T2, a 6-month follow-up would be recommended. In asymmetric cases, that's usually what I elect to do. So let's go over a more detailed algorithm. The first thing to select is whether we have which distribution as per BI-RADS lexicon. Is it linear, segmental, focal, regional, and multiple regions, or diffuse distribution? Now, the internal enhancement pattern is also important. Homogeneous enhancement, if it's segmental linear, requires a biopsy. That's the first branch point. Now, if there's heterogeneous enhancement, when it's not linear or segmental, and we're looking at the other distributions, such as focal, regional, multiple regions, or diffuse, then the internal enhancement characteristics become more important. Clumped, as you can notice, means that there is small nodular enhancement, however, it's completely filled in. Clustered ring enhancement is how I remember is a cluster of grapes. It's almost translucent internally, but there's rim enhancement in this nodular pattern. And of course, branching pattern. Clumped, clustered ring enhancement, and branching pattern, all the heterogeneous types of patterns require a biopsy when we are suspecting DCIS. So we're going to look at a case now of segmental distribution. This was biopsy-proven ductal carcinoma in situ, and we're going to discuss whether this is clumped or clustered ring enhancement. So you can see that on the magnification ML views that there are pleomorphic calcifications extending to the nipple. And we can measure that the calcifications go pretty much from one end to the other end of our magnification views. The tomo biopsy performed also on August 6th, we were able to capture a lot of these pleomorphic calcifications in our specimen radiograph. It was a well-sampled case of pleomorphic DCIS. Our biopsy clip is within the middle of this segmental pleomorphic calcifications. Just as a comparison, you can see here, there's segmental enhancement extending from the pectoralis muscle to the nipple on the sagittal view. So we can see in the left breast that there's enhancement extending from the posterior upper outer quadrant, and more so on the sagittal, we could appreciate that that enhancement goes right up to the nipple. And it's important to look at it in both orthogonal views, the axial and the sagittal plane. Even on the subtraction images, there might be two things that catch your view, and this is a very important part of your full algorithm. I like to start with the MIP, get an overall picture, make sure you were looking at the MPRs, we're not excluding any regions. But after you're done looking at the breast parenchyma, after you're done evaluating the axillary lymph nodes, the internal mammary nodes are very important. Bone lesions are something that are often missed on breast MRI. You can see here that there are two enhancing bone lesions in this patient's sternum. As of now, we only have a biopsy-proven DCIS. We also see on the T1 image that there's no axillary nodal enlargement, pathological enlargement. She did not need a biopsy, but we do have enhancing lesions in her sternum. With bone lesions, the algorithm, it's important to see whether there are any additional bone lesions, so more than one is slightly suspicious. We want to also carefully look at the margins of the bone lesion. We want to know its T1 and T2 characteristics. Sternal bone lesions are worrisome when they're T1 hypointense and T2 hyperintense. We have to exclude fat-containing hemangiomas. Otherwise, consider recommending a bone scan versus a PET scan. Multiplicity is worrisome as well. If there's more than one lesion that's enhancing, make sure to always look at the localizer image to evaluate the spine in addition to the sternum. The non-circumscribed margins tend to be worrisome in a bone lesion, and if they extend beyond the bony cortex. Heterogeneous enhancement is very important to comment on as well. In our case, we reported these as indeterminate enhancing sub-centimeter sternal lesions. The differential diagnosis includes an atypical lipid-poor hemangioma, islands of red marrow. However, metastatic disease cannot be excluded. Correlation with PET scan is recommended. The sub-centimeter indeterminate sternal lesions are unlikely to demonstrate FDG avidity due to their sub-centimeter size. However, the absence of additional metastatic disease would be reassuring. If surveillance is elected after a normal PET scan, 6-month follow-up contrast-enhanced MRI after the surgery is recommended. This way, the surgeon and the medical oncologist can continue on treating the patient with DCIS with their usual surgical treatment, and these bone lesions will be assumed to be hemangiomas or islands of red marrow, and then we will reevaluate. A biopsy can be pursued early as well. As a radiologist, it's your job to describe whether these are fat-containing lesions, if they have T2 hyperintensity, and what the next step with imaging is. So we're back to our BI-RADS card. You want to describe your non-mass enhancement. First, the distribution, which in our case is segmental, and then the internal enhancements, and we're going to decipher between clumped and clustered ring. So on the kinetic map, you can see that there is significant background parenchymal enhancement, but there is type 3 kinetics within the posterior aspect of the segmental non-mass enhancement. And you can see that the clip ends up within the segmental area of non-mass enhancement, and it's triangular, segmental in direction. And I would have described these as clumped non-mass enhancement because clustered ring is usually a peripheral enhancement, and here you have some internal enhancement of this non-mass enhancement as well. Just a side note, when we look at this case on the true images, motion artifact always propagates in the phase encoding direction, left to right on breast MRI, regardless of the direction of motion. Even minimal motion will cause misregistration on subtraction, so make sure to look at the source images to help clarify. One of the things that I always have a difficult time with is in the axilla when you have motion artifact related to the heart beating. So important to not only look at the axilla in your subtraction images, always go back to the T1 post-contrast images to determine whether there are true axillary nodal enlargement and what the cortex looks like on multiple sequences. This is a 30-year-old female who presented with a palpable left breast mass for approximately 1 month. You can see we marked this region with a BB marker. There are pleomorphic calcifications on the 3D evaluation. On the 3D evaluation, we can see that there's architectural distortion associated with a large mass. So the left breast palpable mass corresponded to an irregular mass with a taller than wide morphology, measuring up to 3.1 centimeters. There is internal increase in hypervascularity on Doppler evaluation. And we evaluated the axilla in this patient, and we see some normal morphology axillary lymph nodes at level 2 with a normal cortex measuring up to 0.1 centimeters. You can appreciate here that this is the pectoralis muscle, and there is an enlarged lymph node, irregular looking enlarged lymph node, with no real fatty hilum identified, even on the ultrasound evaluation. You can tell it's reniform. It kept some of its usual morphology of a lymph node, and this was a suspicious lymph node, however, it was retropectoral. The patient did have an ultrasound-guided biopsy of just the 3 o'clock palpable mass, which was invasive ductal carcinoma in a 30-year-old with no significant family history. On breast MRI, because she's so young, so dense, it was an important patient to do a breast MRI on. Ultrasound tends to be the most accurate measurement, but always provide a 3-dimensional volume measurement. The most important measurement for our surgeons also, you want to tell them how deep to go. Is the skin involved? When it's within 1 centimeter, here we can see that it's about 0.6 centimeters away from the skin. It is going to be important to provide that information to your surgeon. Distance from the nipple areola complex and distance to the pectoralis muscle is also very important. It's more obvious on the MIP when you rotate it around that in addition to the index mass, which has already been biopsy proven as invasive ductal carcinoma, there's an additional focus of enhancement. Within the same quadrant, I don't usually recommend an additional biopsy, but it is important to provide a full measurement, including, so you can see here that we have the mass, which measured initially 2.8 centimeters on MRI, and then there's presumably disease in between, but we have a separate focus of enhancement. When it's in the same quadrant, that is multifocal breast cancer. And here I would recommend the preoperative localization to be MRI bracketing because presumably we won't see this small focus of enhancement on ultrasound. If breast conservation therapy is elected, then MRI-guided wire bracketing preoperatively would be the best way to localize this. If the patient or the breast surgeon required an additional biopsy, which is usually the case when it's multicentric breast cancer in another quadrant, then we could do a second look ultrasound if it's a large enough mass. Of course, if it's a focus in an area of non-mass enhancement, going directly to MRI-guided biopsy would be appropriate. The total distance when it's multifocal breast cancer is important to report. The total distance here is 5.6 centimeters, and oftentimes surgeons will tell you that about 5 centimeters of disease is when they will feel comfortable recommending lumpectomy or a partial mastectomy. It's not a steadfast rule that it's always 5 centimeters, especially in a larger breasted patient. I've seen breast surgeons remove 7 to 9 centimeters of disease in the setting of an oncoplastic reduction on the other side. So it is not your decision to lock in the patient to a lumpectomy versus a mastectomy. It's important to provide 3-dimensional measurements of the index lesion that's biopsy proven, the distance where the additional lesions are located, whether they are multifocal or multicentric in location. So remember, multifocal means that they're in the same quadrant of the breast. I would not recommend an additional biopsy. It's guilty until proven innocent. And remember, there's always a possibility that there'll be a false negative. If I did not get breast cancer when I biopsied that small focus of enhancement, my pretest probability was still high enough that it's breast cancer. It would still require a full MRI-guided wire bracketing. When it's in a different quadrant, multicentric disease, often the patient and the breast surgeon elect for an additional preoperative biopsy to prove that the patient has truly bought themselves a mastectomy or a much larger lumpectomy, or sometimes even 2 lumpectomies, depending on the extent of disease. So now we've established that this patient has the index lesion, the additional lesion, there that is, with multifocal disease. And do you remember that ultrasound retropectoral lymph node we'd seen? Let's go ahead and find that. So we have pectoralis major, pectoralis minor. We see a lymph node, but we see normal fat in it, and we can prove that on the T1. And here we see our enlarged lymph node, which is still a level 2 lymph node, but it's retropectoral, which means it's behind pectoralis minor muscle. And I don't see a normal fatty hilum. We can prove that. Always when evaluating lymph nodes, my favorite sequences are the T1 post and the T1 fat bright sequence. I suspect that this is a normal lymph node, and I'm correct because I see a nice, beautiful T1 hyperintense fatty hilum. And this was the abnormal lymph node, and you can see how it's T1 hypointense. And even when looking for fat in there, we are not able to see it. The surgeon did not want a biopsy of this lymph node, but the medical oncologist who was treating this patient wanted to know prior to starting neoadjuvant chemotherapy. And we were able to do an ultrasound-guided biopsy in this region of this retropectoral lymph node. And we did, in fact, find that this patient had involvement of the nodal tissue. In a tumor board setting, it's very important, and this is why we give our 3-dimensional images, to really provide as much information as possible for the TNM staging. Tumor size, 1 to 2 centimeters, is a T1C. Of course, smaller tumors, T1A and T1B, are as depicted here. T2 is anything greater than 2 centimeters. So when you're reporting something that's 2.1 centimeters, be absolutely sure that it matches the ultrasound location and that you are reporting it as a possible T2 tumor, because that could change the management and clinical stage of the patient. T3 is greater than 5 centimeters, and a T4A would be extension into the chest wall, but not including the pectoralis muscle. It's very important that when we talk about chest wall extension, that we use the terminology that's correct. As a radiologist on MRI, only describe what is enhancing. And you can say fibers of the pectoralis major muscle are enhancing, fibers of the pectoralis minor muscle are enhancing. Talk about which bones are enhancing if there is direct extension. But there's no reason to call something T4A. It is the job of the medical oncologist and the breast surgeon to do the final staging. You're only using the terminology and describing the images that you see. Regional lymph nodes are important to mention as well. That's the N of the TNM classification. So when we had no regional lymph node metastases, that would be an N0 by imaging criteria. Of course, the patient will eventually get final surgical staging done based on the surgical status of the lymph nodes on sentinel lymph node biopsy. N1 would be ipsilateral level 1 and 2 axillary lymph nodes. Metastases in the ipsilateral 1, 2 axillary lymph nodes, but they're clinically matted or fixed. Those are N2. Again, that's a clinical diagnosis. Where we can help is in the N3. We want to always provide information about ipsilateral internal mammary lymph node chains, which could be clinically evident. I'm going to provide a companion case here. Another patient here, we see that she has a biopsy-proven ipsilateral 3 centimeter invasive ductal carcinoma. And we also see, this is a pectoralis major muscle, pectoralis minor muscle, that she has a level 2 axillary nodal enlargement, pathologically enlarged. And if you looked at the T1 fat bright sequence, you would see that there's no fatty hilum. And there's additionally a large node in the internal mammary chain. So clinical stage, she would be a T2 because that's a 3 centimeter tumor between 2 and 5 centimeters, and N3 because we have ipsilateral internal mammary chain. And as of now, she's an M0 because we don't know about distant metastases. So this is a 62-year-old female who presented with a palpable finding for about 1 month, initially in December of 2020. There's a small cyst seen, and she was made a BI-RADS 3. She came back and saw me in July of 2021, a little delayed for her BI-RADS 3 6-month follow-up. And this is an important graphic, and probably one of the few times that a radiologist gets to play the role of a clinician. Oftentimes, the primary care doctor will feel the palpable finding and send them for a diagnostic mammogram and ultrasound. They'll feel potentially a 5 centimeter plum-sized lesion, and the radiologist, who may or may not be on site, will find a 1 centimeter cyst, a pea-sized lesion, and say, yep, that probably corresponds to the patient's palpable finding, and make it a BI-RADS 3 if it was a complicated cyst, sometimes maybe even a BI-RADS 2 if it was a beautiful simple cyst. If you are doing a diagnostic mammogram and are on site, it is very important for the radiologist to do their own physical exam. When patients have a palpable finding, try to either get the technologist or yourself categorize the patient with a pea-sized mass, a grape-sized mass, or a plum-sized mass. And then when you see it on imaging, see if it correlates. So this is a patient when she presented in July back to me. I went in and something just wasn't feeling right. She had a very vague, almost immeasurable, but very palpable mass that measured approximately 5 centimeters. And it looked hypervascular here. I couldn't see margins to it, but this did not look like the other side, always compared to the other side. And what was being measured was this small cyst, which measured up to 0.8 centimeters. So something just did not add up here. I scheduled the patient for a same-day ultrasound-guided biopsy of the vague infiltrative mass that she was palpating. It was almost a palpation-guided biopsy rather than an ultrasound-guided biopsy, but it did look different, and it was hypervascular, so I targeted my biopsy to the hypervascular region of the palpable finding. She had no mammographic correlate of note, no calcifications, and no real mass. She was dense, and I think that was worrisome, but there was nothing that we could see in target and stereotactic biopsy either. The pathology we received on this patient was high-grade DCIS, which mass-forming DCIS is uncommon, but it's not unheard of. This patient who had a palpable finding before a true imaging finding, it's usually common clinical vignette for a lobular pathology. It was also a mammographically occult breast cancer at this point, so we decided to get a breast MRI just in case there was undersampling or potential lobular pathology coexisting with the DCIS. And you can see on this MIP that this entire region was involved, and you can appreciate the neovascularity leading up to this non-mass enhancement. When you pull up her sagittal subtraction images, you can see there's coexisting clumped non-mass enhancement and clustered ring enhancement. There are regions of dark, which is telling heterogeneous enhancement. You can see that there is enhancement in a triangular segmental pattern. So this added up that this was a true biopsy-proven high-grade DCIS, occult mammographically, and no additional lesions were needed to be biopsied. Important operative measurements to give and what is important to mention in a report. I'm going to show you this patient's report. This is a biopsy-proven malignancy in the left 2 o'clock 2 centimeters from the nipple location. I like to reiterate where I biopsied on ultrasound and be as specific as possible. The worst thing is to start calling it 3 o'clock when it was truly 2 o'clock on the ultrasound. Keep things as simple for the clinicians as possible so they know that there are no additional lesions. Demonstrates highly suspicious clumped non-mass enhancement. This is the heterogeneous subtype that we talked about, non-mass enhancement. Measuring, and again, I like to give 5.6 centimeters AP dimension, 5 centimeters craniocaudate dimension, and 4 centimeters in transverse dimension. 3 planes, best seen on sagittal subtraction reformat sequence, as we saw, 55 of 146. Make your annotations, save your images, but also provide the image numbers so that the surgeon can go over the key images with the patient. Again, always give key measurements. Abnormal enhancement is noted approximately 0.8 centimeters deep to the closest anterior skin margin and approximately 0.8 centimeters away from the nipple areola complex. Your breast surgeon cares very much about where it's located relative to the skin, the nipple areola complex, and the pectoralis muscles. Here, this was an anterior lesion, so I did not give measurements to the chest wall or pectoralis muscle. I also like to mention what type of clip was placed, susceptibility artifact related to biopsy clip placed on biopsy date within the mass at the inferior lateral aspect, that's a well-located clip. Then we want to really specify what type of localization to do. If breast conservation therapy is elected, preoperative clinical localization of the palpable mass is recommended. If image-guided preoperative localization is elected, MRI-guided wire bracketing is recommended, as this finding is mammographically occult and sonographically vague. Here are the key points again. Use standard BI-RADS lexicon, clumped segmental non-mass enhancement. Provide key measurements helpful in staging and operative planning. Distance to the skin, nipple areola complex, and the pec. Provide key image numbers and save images for your surgeons and patients. Recommend the best modality for preoperative localization and provide pertinent negatives. No MRI suggestion of multifocal, multicentric, contralateral, or nodal involvement. When my referring physicians see that sentence, they know they no longer need to worry about additional biopsies to be performed, and it is a true BI-RADS 6 requiring no additional preoperative imaging or sampling. This patient is a 75-year-old female who had no significant family history, and she had a screen-detected architectural distortion that we see here. I will say that we have switched to all composite view, which is no 2D view, and I've seen sometimes that we'll get artifactual architectural distortion with brightening of this like loop of calcified vessel. So when it was a screen-detected finding, I wasn't 100% sure if it was going to pan out on our diagnostic images. And on 3D evaluation, it does actually stay. And then an ultrasound was done of this region of architectural distortion. And on diagnostic ultrasound, there was a corresponding anterior 10 o'clock, 3 centimeters from the nipple, hypoechoic mass with irregular margins, which was recommended for biopsy. The axilla is usually evaluated at our institution, and there was no cortical thickening noted in the axillary lymph nodes, which were found on ultrasound. The pathology was invasive lobular carcinoma from this architectural distortion with a corresponding mass on ultrasound. Lobular pathology is one of the indications to get a preoperative breast MRI. The reason for this is there is an increased chance of lobular carcinoma having ipsilateral and contralateral findings. One of the things that are often described in lobular pathology is the shrinking breast phenomena. And you can see here that this patient has had no prior surgeries, and her right breast is shrunken compared to the left breast. So on our subtraction sequence, we can appreciate that there is heterogeneous non-mass enhancement, which is a presentation type of lobular carcinoma in the right breast. But there's also clumped non-mass enhancement in the left breast. We see that centrally, but really there's kind of two regions, medially and laterally, in her breast. If you wanted to localize the clip that we had just placed in ultrasound, the best sequence would be a T1 post or even a T1 pre. I like the fat suppressed sequences more. I'm going to zoom in on that, and you can see the clear susceptibility artifact within the region of enhancement. Always provide 3-dimensional measurements of the non-mass enhancement, which may be greater than the ultrasound mass we saw, and this would all be part of the lobular pathology. So she was recommended for not just one left-sided biopsy, but 2 left-sided MRI-guided biopsies. We elected to go directly to an MRI-guided biopsy because of the non-mass enhancement. Non-mass enhancement is often not visualized reliably on ultrasound, and it's important that we get a RAD path concordance we're happy with. Getting breast tissue or fibrocystic change on ultrasound when we didn't have a true correlate would maybe not save this patient from an additional biopsy. So we went to an MRI-guided biopsy. And you may or may not know, but MRI-guided biopsies, you kind of have to pick a team. You have to either approach that enhancement from a medial grid or a lateral grid. In our case, we actually had to biopsy both of those regions, but they were close. And what we ended up doing was doing both the biopsies on the same day. And we chose to come in from medial. And you can see this is my introducer here within the area of enhancement. And you can see again here centrally the two biopsies. So we came medially and we just went a little bit further laterally in a compressed breast and were able to get both biopsies performed. So our pathology diagnosis of the left lateral biopsy included usual ductal hyperplasia, and there was no atypia or malignancy in the lateral. Very important to keep note of which clips were used. In the medial, we actually got ductal carcinoma in situ. So this patient had a right invasive lobular carcinoma, screen detected from architectural distortion and biopsied with ultrasound, and then her preoperative MRI showed concordant left breast DCIS. The MRI-guided biopsy was performed, both of these together, and it's very important to do radiology-pathology concordance on your MRI-guided biopsy and what is acceptable for linear non-mass enhancement. We consider this concordant, but because she has similar DCIS, they are going to be including even the benign biopsy clip in their localization, and there will be an MRI-guided wire bracketing of both the right and the left breast. Presented with left skin erythema and a hard left breast at clinical exam. She had a skin punch biopsy demonstrating infiltrating carcinoma. As you can see, it was negative for the marker E-cadherin, so it was actually read as to favor lobular carcinoma of the breast. It was estrogen receptor positive. It's important to see some of these markers and make sure that it has reason to believe that it is, in fact, a breast primary. Now, an inflammatory breast cancer is what clinically she's presenting as, which an inflammatory breast cancer tends to be ductal in etiology about 85% of the time, so lobular is not uncommon but less likely, and it is often described as an orange peel skin. We can appreciate on her MRI how extensive this breast cancer was. You can appreciate how much skin thickening this is. This is not a post-radiated breast. And the differential diagnosis for skin thickening versus enhancement is very important. So the differential diagnosis can be inflammatory, it can be radiation, infectious, such as cellulitis, or it can be neoplastic, such as angiosarcoma, seen usually post-radiation, or an inflammatory breast cancer, which is what we're dealing with here. When I'm looking at the relationship, you can see the internal mammary vessels here. We can see some of the tributaries of the axillary veins here. In order to look at the muscles, again, you see pectoralis major, pectoralis minor muscle. If there was a node that was interpectoral, that would be called a Rotter's lymph node. I like to look at the T1 post-contrast imaging for involvement of the pectoralis muscle. So this is all enhancement from the skin to fibers enhancing within the pectoralis major muscle. And you can see that on subtraction as well. So here's extensive orange peel skin thickening noted clinically, prompting the biopsy, involving the entire hardened breast. You can see the pectoralis major coming down here and getting kind of involved within this mass, and there's enhancement. And let's look at that again on a T1 post. So you can see that the T1 post will show that there's enhancement of the muscle, pathological enhancement of the pectoralis major muscle. Let's look at that with subtraction. Always triangulate on both sets of images to know what's muscle and what's tumor. So this right here, you can see on T1, it's bright, is a pectoralis major muscle, and when I triangulate, let's get our triangulation tool, there is in fact enhancement within the pectoralis major muscle. Now we describe it, we don't say chest wall involvement. You can see right here, so much enhancement of the pectoralis major muscle throughout. Only if there's osseous involvement, that's when a cardiothoracic surgeon would have to get involved. That's the only time maybe I would verbally in tumor board use chest wall extension. Otherwise, I would just describe in my report pectoralis major enhancement at the inferior aspect. Now this is the major tumor here in the central breast, but of course we see that there is additional enhancement away from the tumor as well, noted laterally. Not that this patient isn't going to get a mastectomy, but just for completeness of report, I would describe that as a separate nodule, separate satellite lesion, multicentric because it's involving now a separate quadrant. And more importantly, there's actually a left-sided irregular mass as well, which is very common in lobular pathology. And we see actually 2 enhancing masses in the left breast. Very, very important. She had a PET CT because of the extensive disease. We're going to talk about the PET CT here. She did not have metastatic disease, but potentially, because this was an FDG avid lesion, even in her, obviously in her right breast, but also in her left breast, the patient did elect mastectomy. The PET can also be helpful to look at the pectoralis muscle and to see if there's a fat plane preserved. Fat plane preservation is important. Let's pull up our side-by-side T1 fat bright sequence. Here's that skin thickening with enhancement in inflammatory breast cancer. Here is a pectoralis major muscle, which we're going to follow its margins here. Here's when it starts meeting the tumor, and I don't see any preserved fat plane. So that is true enhancement of the pectoralis major muscle. Surgeons understand CT better, so it's always nice to get the CT from the PET CT component and showing them that as well, so they can appreciate again that there is no preserved fat plane. The inferior fibers of the pectoralis major muscle are involved here. So some take-home points from this case: be specific and never use the words chest wall involvement unless you want the cardiothoracic surgeon to attend your tumor board. Always describe what you're finding, the features, describe enhancement of the inferior pectoralis muscle, and also describe if there's any preservation of the fat. So let's switch gears and discuss some special examples of various enhancement patterns. So we're back to our BI-RADS note card with the lexicon. Possible shapes include oval, round, or irregular. Margins include circumscribed and not circumscribed. Irregular and spiculated are subtypes. The internal enhancement characteristics, although important, remember margins trumps everything. A special case scenario I want to discuss is rim enhancement of an irregular mass. So unique rim enhancing mass. Rim enhancement on the post-contrast T1 weighted image is within the area where there's high T2 signal as well. If this does not match, as you can see, there's rim enhancement. Biopsy should be recommended of all rim enhancing masses. The high T2 correlate and circumscribed margins shouldn't deter you from the biopsy. Let's discuss a specific case. This is a patient who presented 51-year-old. She had a family history of breast cancer, and her paternal grandmother diagnosed in her 50s and a paternal aunt with breast cancer diagnosed at age 45. She had a screen-detected mass, which you can see on her subsequent spot compression views. Some architectural distortion associated with it as well. And anterior to that, I think it was a good pickup, there's some faint punctate microcalcifications. An ultrasound-guided biopsy was performed, as well as a stereotactic biopsy of the calcifications. The screen-detected mass at 10 o'clock, 8 centimeters from the nipple, demonstrates suspicious morphology, taller than wide, and measured up to 1.6 centimeters. Remember, on ultrasound, things look awfully close to the pectoralis muscle, but when you have a patient, MLO, mammographically is the best indicator to see intervening fat, and also MRI will tell you that it's not actually as close to the pectoralis muscle as it appears. Another way to check for pectoralis muscle involvement is to float up the lesion with a lidocaine, and you can sometimes see a nice fat plane and see that the mass is actually in fact separate from the pectoralis muscle. So this patient had a biopsy-proven invasive ductal carcinoma corresponding to the mass seen on a screen-detected mammographic finding. Additionally, there was a benign stereotactic biopsy done. We can see that we have our irregular, spiculated, homogeneously enhancing mass corresponding to our site of ultrasound-guided biopsy. I see nothing else worrisome in the left breast or left axilla. The best sequence to find the clip would be a T1 pre or post with fat saturation to see the susceptibility artifact. However, kind of surprising in a patient with ductal carcinoma, but she is dense, so that's why we chose to do this MRI. We can also see there's some motion artifacts, so we may go to our source images to correct that. Remember, motion artifact is in the phase encoding direction, which is left to right in a breast MRI, that there's quite a bit of enhancement in the right breast above background. So we see some non-mass enhancement more focally in the right 12 o'clock breast. Additionally, and I'm going to go to the source images here to really evaluate. Additionally, we can see the T1 post-contrast images, the source images, have a whole lot less motion artifact, that not everything that lives in the axilla or even axillary tail is a lymph node. So you see some nice normal fat-containing hilar hypointensity on this fat-suppressed sequence, right? On the ipsilateral side on the left, where we knew we have the cancer, I see some nice chunky lymph nodes, but normal morphology on the right. This is just not the same. This is a really good example of a rim-enhancing mass. I think if somebody was reading this in a hurry, this could have been passed as a normal lymph node. But the observer noticed, even though there were washout kinetics, the morphology, it almost looks like there's some ductal extension. It's irregular. Remember, margins of a lymph node should be smooth. So now we're going to go to our fat-containing sequence. I can't quite get fat in it. I can see that there's maybe some internal hypointensity, but definitely not fat. Let's go to our T2 or stir sequence, which would show us some fluid, and maybe it'll show us some necrosis. We see that there's a T2 bright correlate, and again, margins are not well maintained. We decided to go ahead and take her to ultrasound of the right side, and lo and behold, there was something that was not a lymph node. We see an irregular mass at 11 o'clock, 12 centimeters from the nipple, way up there in the axillary tail. A patient with known left ductal carcinoma, MRI found yet another right axillary tail mass. We did do an MRI-guided biopsy of the right 12 o'clock non-mass enhancement as well. The ultrasound-guided biopsy demonstrates invasive ductal carcinoma in the right axillary tail, and MRI-guided biopsy of the superior 12 o'clock non-mass enhancement was focal usual ductal hyperplasia. Usual ductal hyperplasia and fibrocystic change is an appropriate RAD path concordance on MRI-guided biopsy. So let's review some take-home points from this case. Not everything that enhances in the axillary tail is a lymph node. Look at the margins very carefully. Look at if it is a rim-enhancing mass, which we saw, which requires a biopsy. The axillary tail would be really difficult to get to, so I'm glad that we were able to find an ultrasound correlate. When a mass is that large, an ultrasound correlate should be identified. And we talked about some of the suspicious features of masses that require biopsy, the margins and the enhancement patterns. This is a patient who presented to us, 65 years old, no significant family history, and she had new right upper outer quadrant punctate and coarse heterogeneous grouped microcalcifications on her screening mammogram. At this point, we were one of the trial sites for the intact excisional stereotactic biopsy, which is, as you can see, a fairly large device. It was actually a 2-gauge, and we used to put lidocaine all throughout. And this heated wire basket operates and kind of removes and does an excisional biopsy. The specimens are fairly large, and you can actually do some margin analysis as well. So we removed the entire group of microcalcifications. You can imagine with so much lidocaine and a 2-gauge device that there's a fair amount of post-biopsy change. So this is her magnification views. Fairly benign looking microcalcification when we first saw them, but they were new, so they were appropriately recommended for biopsy. And there was a focus of invasive lobular carcinoma found associated with the calcifications. Now, it looked like we got all the calcifications out. The clip was well located. So she gets a breast MRI for a focus of invasive lobular carcinoma associated with those tiny microcalcifications. And we see focal non-mass enhancement, and that's actually a couple centimeters away from her biopsy clip. We took a fairly large specimen from her, so it's possible that it was in the center of where we biopsied, or this could be residual non-mass enhancement from an unsampled area, kind of tip of the iceberg that we saw on mammogram, and then there was more enhancement related to this lobular carcinoma on MRI. Again, you can notice that the subtraction images demonstrate quite a bit of motion. MIP, it's important to kind of spin this around, and perhaps you can see that this looks very tubular, but it's cut off. Now on the subtraction images, follow our area of linear non-mass enhancement. And again, it looks pretty tubular, but we can't connect it to any of the other vessels like we can on the left side. So this was called a linear non-mass enhancement. Now let's look for post-biopsy change. Our T1 and T2, they're going to show the blood products, so we really want to look at our T2 sequence and appearance of the biopsy clip. We tend to mark the scar where we went in on MRI. You can actually see that the gel foam around the biopsy clip shows a nice T2 bright fluid signal. Not a whole lot of blood products there. Let's go ahead and confirm that on our T1 as well. And the best T1 here is we want to pull up the first pre-contrast sequence. And now we know where our clip is, so let's triangulate on the clip. And I don't see a big T1 bright hematoma. I do see susceptibility artifact related to the biopsy clip. So this susceptibility artifact is related to the titanium in the clip. The T2 bright signal is related to the gel foam in the clip. Now, relative to the susceptibility artifact, that linear non-mass enhancement was located slightly remote. So let's go ahead and go back to the clip. And we see no enhancement next to the clip, but that linear non-mass enhancement is here. So of course, we schedule her for an MRI wire localization the day of surgery, and it is completely resolved. And let's bring that up here. We ended up just localizing her clip in stereo and sent her off to surgery. And it turned out we'd actually removed her entire lobular carcinoma on our intact excisional biopsy. But let's see. So again, you see that grid that we place laterally. And we have subtractions available, but there was no additional enhancement. Potentially this was a vessel that was compressed. As you can tell, on the day of the biopsy, you're not just in a breast coil, you also have additional compression from the grid. So sometimes you can actually compress out a little tiny blood vessel. She has now been cancer-free for the next 3 years. We've actually done follow-up breast MRIs on her, and we were able to show that the entire lobular carcinoma was truly removed. So let's talk about some take-home points on this case. Want to go over how we evaluated post-biopsy change versus true enhancement that's pathological. So look for the clip on your T1 pre and your T1 post fat suppressed sequences. Find your T2 bright area of gel foam in your biopsy clips as well. Susceptibility artifact is best seen on T1. Now, to evaluate the vessel, make sure you're spinning the MIP. You might have a cutoff vessel because you can see that the entire vessel did not light up. It's not a static image. Make sure you're spinning your MIP. So this is a patient who presented to us, 32 years old, family history of breast cancer diagnosed in her mother at age 47. And she presented with a right breast palpable finding. Mammographically, this was occult. There was a BB placed on it and nothing was seen on the right side. And incidentally, on the left, we found a focal asymmetry. Targeted ultrasounds were done on both sides. The same day as her diagnostic mammogram, we did the diagnostic ultrasound, and the palpable finding really stuck out like a sore thumb on her ultrasound because she's fairly dense, and even though it was mammographically occult, right 10 o'clock, 2 centimeters from the nipple, we had a 2.3 by 1.7 centimeter mass, which was irregular and some internal vascularity. We looked to find a correlate for the left finding as well, and there was a small correlate found at left breast 9 o'clock, 6 centimeters from the nipple, fairly posteriorly. She went to our breast surgeon, and this is kind of a pet peeve of mine. I like to keep things very similar. The day of our diagnostic, we called her palpable lesion 10 o'clock, 2 centimeters from the nipple. The breast surgeon called it 12 o'clock, 2 centimeters from the nipple. It's obviously the same lesion, and it's a fairly large lesion, so that was sampled. This came back invasive ductal carcinoma. At this point, she still hadn't had her left breast biopsy, so she went back to the breast surgeon. And the region that we had found to correspond with her mammographic finding was left 9 o'clock, 6 centimeters from the nipple. Although this is labeled left 9 o'clock, 6 centimeters from the nipple, and I can't see in any of the images whether the lesion was actually sampled or not by our breast surgeon. No post-biopsy mammogram was done. The left breast was benign, and it was called concordant. It was just called benign breast tissue with fibrocystic change. At this point, a breast MRI was ordered. She's fairly young. She's dense. She had a mammographically occult mass. All good reasons to get a breast MRI preoperatively. So we see lots of enhancing masses in the right breast. The largest one was biopsied, and the clip is in accurate position. This is an example of multifocal because we're in the same quadrant of the breast. And also multicentric disease below the nipple. She has extensive multifocal and multicentric disease. Additional focus in the anterior upper inner quadrant as well. So now let's take a look at where our clips are. So here is again our site of entry. You can see some enhancement there that was unsampled, and then we see our biopsy clip, fairly external to the larger site of enhancement. scratch that internal to the area of enhancement here. That's the only sampled area. There's lots of other multifocal and multicentric disease. On the right side, let's continue on with our search. We see a pathologically enlarged lymph node, rounded morphology, not a lot of fat. This is suspicious. Because there's so much disease, we want to make sure we look at the sternum carefully on our T1 post. We want to make sure we look at our internal mammary vessels carefully as well. And as of now, the left breast has multicentric disease and axillary nodal involvement. Now, the benign area that was biopsied, we can see our surgeon clip. We didn't have a post-biopsy mammogram, but we do have a post-biopsy MRI, is located here in the anterior breast. The area of enhancement and irregular mass is located here in the posterior breast. So although she was in the right quadrant, we didn't actually sample this. Unfortunately, the patient elected to have a mastectomy with a deep reconstruction. She jumped around from location to location, so I don't think the lack of concordance in the left breast was communicated to them. So the bilateral mastectomy specimen, there were 3 separate foci of IDC identified in the right breast, and the left breast was called benign. Unfortunately, we never really resolved what was truly at 9 o'clock 6 centimeters from the nipple. Her story doesn't end there. She had a right skin recurrence found on punch biopsy in 2021. So she got a PET scan. In 2021, lots of people were starting to get COVID vaccinations, and you can see on her PET scan that even though she had a right-sided skin recurrence, you can see surgical clips throughout both breasts from her deep reconstruction, she had lots of large left axillary lymph nodes. These were called very suspicious, and a biopsy was recommended. We did an ultrasound, and we were able to gather that additional history. We were able to say it's the upper limb, it's a normal, nice fatty hilum, probably reactive lymph nodes in the setting of COVID vaccination. We repeated that PET scan from May to June, so about 6 to 8 weeks, and the FDG avidity, although the lymph nodes are still there, has decreased substantially, which cancer would not do. And this was proven to be, without a biopsy, reactive adenopathy on PET CT. It's important to continue getting the same history from your COVID vaccination history that you get on your mammograms and screening mammograms, also on your diagnostic mammograms and your MRIs and PET CTs. So this is a patient who's 30 years old and has no family history of breast cancer, and she presented to us with a palpable left breast lump for 2 months. We're going to take a peek at her MRI. What I want to focus on this case is some nodal anatomy. So we want to really be looking at our level 1, level 2, and our level 3 axillary lymph nodes. The low axillary group, they're the sentinel lymph nodes. So when contrast is injected, the blue dye and our nuclear medicine dye, they tend to go to the lower level axillary nodes. It's very important because the level 1 and the level 2 nodes are the ones that are included in our axillary lymph node dissection. When you have a positive sentinel lymph node, presumably your surgeon's going to do a full axillary lymph node dissection when it's above their criteria to do that. But level 3 nodes, or the high axillary and apical lymph nodes, so very important in your MRI reports to always mention high or apical axillary lymph nodes that are medial and superior to the pectoralis minor muscle. Internal mammary lymph nodes are also important to mention because they may not map out. And if there is a node hiding in there, it may change the management preoperatively and operatively, and we want to absolutely give that information. So now let's go to our patient's MRI, the 30-year-old. So her palpable tumor was biopsied. I'm in the T1 post, and we can see the irregular mass. You can see that we marked the area where we biopsied from. And let's look at her lymph nodes as well. So you can see the pectoralis major muscle, the pectoralis minor muscle, clearly. We are scrolling inferiorly. Now we're going to be scrolling superiorly towards the head. And we see a lymph node that's normal morphology, right? Lateral to the pectoralis major and minor muscle. And then we see a pathological lymph node hiding out behind pec minor. So this is still a level 2 lymph node, but important to mention. It can be biopsied, which we did biopsy her. You can see it's posterior to the pectoralis minor muscle, and it was biopsied there. Let's go back to that MRI. Remember, your MIP is not a static image. You can actually even go through all the phases. So you can see time point 1, 2, 3, and 4 to get an idea. And you can spin around your MIP as well. So you can see that enlarged retropectoral level 2 axillary lymph node. You can see your index lesion. And then you also see this focus of enhancement. Sometimes it's not so clear on our axial evaluation, but on our sagittal image, you'll be able to truly appreciate the multifocal disease. And in this case, of course, because of the multifocal disease, we recommended an MRI guided wire bracket. So you see the extent of disease, irregular mass, spiculated, the index lesion. You can clearly see the susceptibility artifact related to the biopsy clip. And then you see a focus of enhancement inferiorly. Important to give this 30-year-old an idea of how much of her breast will be removed in a lumpectomy, and it would be about 5.8 centimeters. Let's go over the key points here. We want to recommend an MRI wire bracket in this patient with a focus of enhancement. It does not require a biopsy typically by the patient or the surgeon because it's guilty until proven otherwise. We want to carefully look at our nodal anatomy, specifically in the T1 post contrast. You can see the enhancing pectoralis muscles and describe the relationship of the enlarged and morphologically abnormal lymph nodes in relationship to the pectoralis muscles. It's important to know when to recommend or expect an order for preoperative breast MRI. Not every single cancer diagnosis gets a breast MRI. The American College of Radiology has an appropriate use criteria, and they say that MRI with contrast may be appropriate in this setting. The NCCN guidelines say breast MRI is optional for clinical stage 1, and special consideration is given for mammographically occult tumors. Remember, mammographically occult tumors tend to happen within dense breast tissue, so it can be read as mammographically occult or heterogeneously dense breast tissue or extremely dense breast tissue, especially in younger patients. Now, it's important to know your audience. Most of your audience that recommends a breast MRI and is going to benefit from the read of a breast MRI tends to be a breast surgeon. And it's important to read their consensus guidelines and official statements. If you look at their consensus guidelines, breast surgeons are very split on their use of breast MRI. For example, the two main breast surgeons who refer to our practice, one of them uses these society guidelines, and the other breast surgeon gets an MRI on every preoperative biopsy-proven malignancy. There's variable specificity reported, 30 to 90%, and of course, MRI has the greatest sensitivity, but the false positive rate is very common, as we've discussed. Their biggest issue is they have guidelines to meet that they want to get the patient from biopsy-proven malignancy to the operating room within 30 days. MRIs tend to increase time to treatment. Therefore, it's very important that you streamline the process for your breast surgeon in order to get additional breast MRI referrals if that's a goal. I also make it easy that when I'm giving a rad pathology addendum with my positive cancers, my addendum looks like this. I have the pathology results. I talk about the concordance with imaging finding. If we evaluated the axilla and ultrasound already, accuracy of the clip placement or whether there was migration, so far what the preoperative localization technique would be, and if there's any indications for preoperative MRI. Sometimes if it's a lobular pathology, I'm very, very clear that it's a lobular pathology. If it's mammographically occult cancer, I'm very, very clear. Other times I just delete this whole indication out and leave it up to the breast surgeon. So again, let's review what the American Society of Breast Surgeons recommend. They think that occult breast cancer in the setting of Paget's disease is very important. They're able to find an ipsilateral cancer focus, 60 to 70%. Also, when there's axillary nodal positive disease and we don't have an occult cancer that was found on mammogram or ultrasound, lobular pathology or extremely dense breast tissue. And of course, it's not a done deal, but if it's in HER2 positive disease, neoadjuvant chemotherapy is often monitored with pre-neoadjuvant and post-neoadjuvant chemotherapy breast MRI. Now, let's quickly take a look at an MRI that was not indicated. So you can tell on the T1 images here, this is a fatty distribution. You can see that the only thing happening in her breast is this tiny irregular mass that was already biopsy proven. And there's no reason to think that there's going to be a tumor hiding in these fatty breasts, right? So she was 63 and no family history. So by age, by breast density, by pathology, she had an invasive ductal carcinoma that was clearly screen detected in these nice fatty breasts. Nothing else is going on. Her nodes were negative on her ultrasound and her MRI. So let's summarize. The guidelines for preoperative breast MRI should be specific. Your radiology-pathology addendum from biopsy should signal that if there's a really good reason, such as lobular pathology or dense breast tissue or mammographically occult breast cancer, that the radiologist demands a breast MRI if the patient, of course, is eligible for one and willing to undergo one. We should know our American College of Radiology appropriate use criteria of when to recommend it, but also know your Society of Breast Surgeon guidelines so you can recommend it based on those guidelines as well. So this is an 81-year-old female who presented to us with a screen-detected mass. You can see there's some architectural distortion. There are some calcifications, but they were thought originally to be mostly dystrophic calcifications and maybe rod-like calcifications. We did an ultrasound-guided biopsy because there was a correlate. The ultrasound correlate measured about 0.7 centimeters posteriorly located, some peripheral vascularity irregular and taller than wide. The pathology results were invasive ductal carcinoma, but there was some associated ductal carcinoma in situ. Our breast surgeons consider this kind of an intermediate reason to order a breast MRI when we get kind of surprising DCIS. DCIS can have skip lesions on pathology, and it's important to know why we got the pathology results of DCIS when we were expecting mostly invasive ductal carcinoma. We look at the subtraction images here, and we see some mass enhancement. We see susceptibility artifact related to the biopsy clip anterior to that mass enhancement, which was an ultrasound-guided biopsy we did. But we also see a lot of non-mass enhancement concurrently. And on the axial, you don't see exactly how far it goes, but you can see that it goes more than you would expect it to go. On our sagittal images, you can see that there's actually extension to the nipple areola complex, about 5.2 centimeters. It's important to give the total extent of disease with the mass plus non-mass enhancement because that's what will be removed, and for surgical planning, you want to provide that information. It's important to give the distance to the skin, and this was 1.1 centimeters in the upper inner quadrant. Important to give the location of the clip, and of course 3 dimensions in craniocaudad, AP, and transverse. I like to go back to the mammogram now. And we can see that MRI can often actually make you a better mammographic reader as well for screeners. When you look at the right MLO compared to the left MLO, of course there's a mass and architectural distortion you see on 3D images, but you can also see that there's ductal fullness kind of going through and through. The MRI shows you that it's truly extending to the nipple areola complex, and that can be appreciated when you compare the right side to the left side, that there was more that met the eye. It's not really the calcifications that were the issue, but it was actually the ductal fullness, which could trigger us that there was more than just mass enhancement.